Welcome back to the deep dive, where our mission is to take complex, critical source material and really just distill it into immediately useful knowledge. Today, we are undertaking a deep dive into one of the most, I think, transformative and clinically demanding areas of medicine, intrapartum care.
It's a huge one, and we're using a really comprehensive clinical guide as our roadmap. When we talk about intrapartum care, what we're really defining is the entire sequence of events that takes a patient from the onset of labor,
The very beginning.
all the way through the delivery of the baby and the placenta, and right into that immediate postpartum recovery period. It's a huge topic, but the sources we're using provide an incredibly structured, stage-by-stage guide.
And I think that's so important. Our goal for you, the listener, is pretty simple. By the end of this deep dive, you should be able to grasp the essential clinical objectives of each stage. Understand the decision points that dictate when to intervene, and know the monitoring techniques that keep both the parent and the neonate safe. We really want you to feel thoroughly informed, not overwhelmed.
Well, and we have to start with the core philosophy, which is just so central to all modern obstetrics, while recognizing the need for intervention, and that's timely evidence-based intervention, is vital. The default focus for the majority of patients, it should always be supporting the normal physiologic process. We're guides to a natural event, really, but we have to be ready to pivot instantly when safety demands it. It's this constant, nuanced balancing act.
Okay, so let's unpack this structure. This clinical roadmap, it organizes the whole experience into 4 sequential stages, which, as you just mentioned, dictate the exact management approach needed at any given time.
Precisely. And understanding these boundaries is how clinicians organize their care and their timing. So stage 1 is the long one. This begins with the onset of regular, painful contractions, and it concludes when the patient reaches complete cervical dilation, which is 10 centimeters. And this stage alone can be subdivided, which we'll definitely get into.
Okay.
Stage 2 is the expulsion stage. It starts the moment the patient is 10 centimeters dilated, and it concludes with the actual delivery of the neonate.
The pushing stage.
Exactly. Then stage 3 is brief, but it's fraught with risk. It covers the time from the delivery of the baby to the delivery of the placenta. Its primary focus is really on maternal safety. And then finally, stage 4. This is that critical immediate postpartum period, generally encompassing the first 2 to 3 hours post-delivery, and it's all about stabilization and bonding.
That structure gives us the trajectory, which is perfect. But we have to start at the entry point. A laboring patient arrives, and clinicians immediately need to triage. So before we can even talk about stage 1, we have to know, how is this delivery going to occur? What does that focused initial assessment look like?
Right. The first step is a focused history and physical exam, or H&P. You have to quickly identify the patient's risk profile, previous surgeries, chronic conditions, any complications during this pregnancy, because that stratification determines all subsequent management. But the 3 core interconnected real-time assessments are determining fetal presentation, monitoring the fetal heart rate, or FHR, and tracking the intensity and frequency of uterine contractions.
Okay, so why is identifying that risk profile so vital right at the outset? Does a history of, say, a prior C-section, does that change the threshold for intervention?
Oh, it absolutely does, 100%. The patient's risk status dictates everything from the safety margin for a trial of labor to how frequently we need to monitor the fetus. For instance, a patient attempting a vaginal birth after cesarean of VBAC has a higher baseline risk. That means a non-reassuring FHR pattern might trigger an emergency response far, far sooner than it would for a low-risk patient. Risk identification is really the foundation of tailored care.
That makes sense. Let's focus on fetal presentation then. Knowing which part of the baby is coming first is, well, it's foundational. How do practitioners actually confirm the positioning?
So there are 2 main methods. The most common modern approach is utilizing ultrasound. It's fast, it's non-invasive, and it gives you a clear visual confirmation of whether the fetus is presenting vertex, which is head first, breech, so buttocks or feet first, or transversely. Crucially, though, if the cervix is dilated sufficiently, usually we're talking greater than 2 to 3 centimeters, the practitioner can perform a digital exam. They use palpation to feel the presenting part.
Okay.
And knowing the exact orientation, not just the part, is also key. We'll cover that a bit later when we discuss the difference between occiput anterior versus posterior positions.
Okay. Here is where the source material gets into the really high stakes of labor physiology. You mentioned FHR monitoring, and the source explains this fundamental physiological challenge that every single contraction represents. This is where monitoring becomes a life safety issue.
This is such a critical insight. Each uterine contraction is a temporary interruption of oxygen delivery. The muscle fibers of the uterus contract powerfully, and in doing so, they temporarily clamp down on the blood vessels that supply the placenta. So this transient decrease in uteroplacental blood flow, it reduces the oxygen exchange to the fetus. If the placenta is healthy and the contractions are normal, the baby recovers instantly between contractions. No problem.
But if the fetus shows signs of non-reassuring status, if that heart tracing suggests the fetus is struggling to recover oxygen, what specific patterns are clinicians looking for that signal a crisis is happening?
The most concerning patterns involve decelerations in the fetal heart rate that are not benign. Clinicians are primarily concerned with what are called late decelerations. These are FHR drops that begin after the peak of the contraction, and they return to baseline well after the contraction has ended.
Okay, so the recovery is delayed.
Exactly. That timing indicates uteroplacental insufficiency. Basically, the placenta isn't recovering fast enough to supply oxygen. Another red flag is severe variable decelerations, which suggest umbilical cord compression. Both of those signal an urgent need for intervention, which we call intrauterine resuscitation.
So when a non-reassuring pattern like that is identified, what's the immediate first-line clinical toolkit? What are the steps for intrauterine resuscitation?
The goal is immediate maximization of fetal oxygenation and blood flow, and you always start with the conservative, non-pharmacological steps. First, position changes. The patient is immediately moved off their back, usually to the left lateral position, to take the weight of the gravid uterus off the major blood vessels, specifically the inferior vena cava.
Right, to improve blood flow back to the heart.
Exactly. It dramatically improves venous return to the mother's heart, which in turn increases blood flow and perfusion to the uterus and placenta. It's a simple move with a huge physiological impact. Second, an intravenous fluid bolus. This rapidly increases maternal intravascular volume, which can also help boost uterine blood flow. And third, supplemental oxygen is often administered via face mask to the mother. This increases the oxygen concentration gradient that's available for transfer across the placenta.
And what about managing the contractions themselves, since they're the source of the stress?
That's the next step. If the patient is undergoing augmentation, meaning they are receiving uterotonic medications like oxytocin to speed up labor, that medication must be discontinued immediately. If the fetus is still profoundly distressed, or if the contractions are just way too frequent, a condition we call tachysystole, we escalate to pharmacological management of the uterus itself by administering a tocolytic medication.
Cocolytics. That's a medication to relax the uterus, right? To give the fetus a break.
Exactly. A common tocolytic is terbutaline. Its function is to halt the contractions temporarily. It gives the fetus a critical window, maybe 5 or 10 minutes, to recover its oxygen reserves and return to a reassuring baseline heart rate. It's the clinical equivalent of hitting the emergency brake on labor to protect the passenger.
That seems like a really definitive moment of truth. What if these conservative interventions fail? If the tracing doesn't improve, how quickly does that decision escalate?
If all the conservative efforts, the position changes, the fluids, the oxygen, stopping the uterotonics, and even the tocolytic, if they all fail to show rapid improvement, the clinician must pivot immediately to an emergent C-section. The sources stress that minutes matter here. This is why continuous monitoring during labor's most active phases is so intense. It provides the real-time data needed for that life-saving pivot.
But let's bring it back to the low-risk patient for a second. We established that if the initial monitoring is reassuring, this level of intense, continuous surveillance might not be necessary.
And that's the key distinction that supports the patient-centered philosophy. If the initial assessment places the patient in the low-risk category and the initial FHR tracing is reassuring, those patients can safely undergo intermittent monitoring throughout labor. This allows for far greater patient mobility, it supports natural labor progression, and it avoids the unnecessary anxiety and discomfort of being, tethered to a continuous monitoring machine. It really respects the physiological process.
Excellent context. So, assuming we've completed the assessment, we've identified the risk, and we've addressed any immediate concerns, or confirmed the patient's low risk, we arrive at the main decision point, determining the mode of delivery, trial of labor, or direct progression to a C-section.
It is the definitive fork in the road, and the source material outlines some specific, non-negotiable contraindications that immediately rule out a trial of labor and mandate a C-section for safety.
So what are those hard stops, the situations where a trial of labor is just simply too risky?
They fall into a few categories: structural, fetal, and maternal. Structural issues would be conditions like placenta previa, where the placenta is covering the cervical opening. A vaginal delivery would be impossible without a catastrophic hemorrhage. Fetal concerns include certain fetal malpresentations that can't be corrected, like an uncorrectable transverse lie, or persistently non-reassuring fetal heart tracing that requires immediate delivery.
And what about the patient's autonomy in this decision? That has to play a role.
It's a third critical category, maternal autonomy. If a patient expresses a firm, informed maternal request to defer a trial of labor and proceed directly to a planned or scheduled C-section, that is an absolute contraindication to attempting labor. The patient's preferences and rights are paramount, provided the decision is informed.
So if the path is clear, if there are no contraindications to proceeding with a trial of labor.
Then the clinical focus shifts entirely to managing the labor process itself. We move right to determining where the patient is within the 4 stages, and that's based primarily on the degree of cervical dilation.
Okay, stage 1, the marathon of labor. This is often the longest and the most variable in its progression. It spans from the onset of contractions all the way to 10 centimeters of dilation. But the most important management decision within stage 1, it seems to hinge entirely on a single clinical threshold, 6 centimeters.
That's the crucial hinge point, defining the difference between the latent phase and the active phase. Historically, the transition was thought to occur earlier, maybe around 3 or 4 centimeters. However, modern evidence has pushed that threshold to 6 centimeters, and that redefines when truly predictable cervical change is expected.
Let's look at the latent phase then, everything under 6 centimeters. If progression isn't really expected, what's the clinical goal during this phase?
The latent phase, so less than 6 centimeters dilation, is a time where labor progresses at a highly variable rate. The clinical goal is expectant management, often called the watch and wait approach. This phase can sometimes last for days for first-time parents without being problematic, and the source material explicitly emphasizes that a prolonged latent phase is not inherently associated with adverse maternal or neonatal outcomes. This is a vital piece of information that helps reduce unnecessary intervention.
I can imagine for the patient, just knowing that a slow latent labor isn't dangerous must fundamentally change their early experience. It probably encourages patience and movement.
Exactly. It supports low-intervention birthing. Many low-risk patients prefer and are encouraged to spend this time in the comfort and privacy of their own home. Admission to the hospital during the latent phase is generally reserved for clinical necessity like for high-risk pregnancies, such as preeclampsia, or if the patient proactively desires an early intervention, specifically wanting neuraxial anesthesia, or if they require augmentation due to maternal exhaustion or just a desire to expedite things.
So under 6 centimeters, it's mostly hands-off. But once we hit that 6 centimeter mark, we transition into the active phase, and the vigilance escalates significantly.
Correct. The active phase, defined as 6 centimeters dilation or more, is characterized by more predictable and rapid cervical change. The risk profile shifts because the labor is now intense and it demands more from the fetus. For this reason, inpatient care and active management are universally recommended.
What does that active management look like if we identify that progression is slowing down in this critical phase?
If the rate of dilation slows down, meaning the patient is no longer meeting the expected curve of progression, then intervention or augmentation is necessary. The clinical term for this is failure to progress in the active phase, and it requires immediate action. The 2 main augmentation strategies are, first, artificial rupture of membranes, AROM, or breaking the water. This allows the fetal head to descend and put more direct pressure on the cervix, which often stimulates faster dilation. Second is oxytocin utilization. We use oxytocin to enhance the strength, duration, and frequency of contractions. This is a very carefully titrated medication, often starting low and increasing the dose incrementally until adequate contraction patterns are achieved.
What's a clinical consequence if, despite these interventions, the ROM and the oxytocin, the patient still fails to progress in that active phase?
That failure to progress is a hard indication for a C-section. We've used our tools to try and assist the physiological process, but if the baby cannot navigate the pelvis or the cervix simply won't open, continuing labor only increases the risk of maternal exhaustion, infection, and fetal compromise. It becomes a clinical necessity to intervene surgically.
Okay. Moving on from the mechanics of dilation, let's talk about a huge factor in stage 1 management, pain management. This is often the primary driver for a patient's decision-making regarding when to even come to the hospital.
Oh, absolutely. Patient autonomy and choice are paramount here. Pain management can be requested at any point, and the clinical team must be ready to support that decision.
So the gold standard for pain relief in labor is neuraxial anesthesia, what most people call the epidural. What are the key pros and cons that have to be weighed?
Well, the primary pro is profound effective pain relief. This allows the laboring patient to rest, to conserve vital energy and move through the often exhausting active phase with much greater comfort. However, the main drawback is reduced mobility. While modern epidurals can sometimes allow for limited movement, they still fundamentally limit the patient's ability to use positioning techniques that might assist labor progression, and they often necessitate more intensive monitoring.
For those seeking some pharmacological relief but who may not want a full epidural, intravenous opioids are an option. But you mentioned a pretty serious timing caution linked to their use.
Yes, this is a critical clinical detail. Opioids like fentanyl or morphine cross the placenta readily. While they provide systemic pain relief, they must be avoided as the patient nears delivery. The risk is that the opioid concentration in the fetal system can cause respiratory suppression in the newborn. That means the baby may struggle significantly to breathe immediately after birth and could require resuscitation. So timing is everything. They're usually only safe in early labor.
And then there's a middle ground, which offers pain relief while maintaining full mobility and control, and that's nitrous oxide.
Nitrous oxide is highly effective because it is self-administered via a face mask. The patient holds the mask and inhales the gas. It's a blend of nitrous oxide and oxygen as a contraction begins, and the effects wear off very quickly. It doesn't eliminate pain entirely, but it takes the sharp edge off, and because of its short half-life, there's minimal residual effect on the neonate. It provides a sense of control, which is incredibly empowering for the patient.
Finally, the source material emphasizes the importance of non-pharmacological options, which are so central to truly patient-centered care.
These strategies are essential because they empower the patient to manage pain physiologically. They include structured methods like hypnobirthing, which uses guided visualization and deep relaxation, water submersion in a tub, which reduces gravitational pressure and promotes relaxation, patterned breathing techniques to manage contraction intensity, and various positioning techniques, like using birthing balls or maintaining upright postures to utilize gravity. The availability of this whole spectrum of choices ensures the pain management plan is tailored to the individual's philosophy and needs.
Okay, we've covered the pace of labor and comfort measures. Now let's pivot back to the clinician's toolkit for advanced monitoring and prophylaxis during stage 1. First, simple fluid management. Is an IV start just automatic for every laboring patient?
No, not universally. 4V fluids can generally be deferred unless the patient is unable to adequately take clear fluids by mouth. Maintaining adequate hydration is key, but if the patient can drink, deferring the IV helps maintain that low-intervention, mobility-friendly approach. However, if the patient opts for an epidural, an IV is required for the fluid bolus that's given before the procedure to stabilize blood pressure.
Let's delve into the technological aspect of monitoring. We know the decision between external and internal monitoring methods is a vital one.
The decision is always driven by risk assessment. External monitoring, using Doppler and dynamometry straps over the abdomen, is the standard for low-risk patients, and it can be intermittent or continuous. Internal monitoring, however, is reserved for high-risk situations where the external tracing is ambiguous or where we need precise, objective measurements of uterine activity and fetal response that external tools simply cannot provide.
This is where we need to explain the technology clearly. So let's start with the fetal scalp electrode, or FSE. How does it work, and why is its data so much better than external monitoring?
The FSE is a small spiral wire electrode that's attached directly to the presenting fetal part, usually the scalp through the dilated cervix. Its superiority lies in its precision. It directly counts the R wave on the fetal ECG, their electrocardiogram. External Doppler monitors rely on bouncing sound waves off the fetal heart, which can be interrupted by maternal movement or obesity. The FSE gives a true beat-by-beat reading, which eliminates ambiguity. That's essential when the fetal tracing is already non-reassuring.
And the second internal tool is the intrauterine pressure catheter, the IUPC. This is fascinating because it measures contractions from the inside and has a great secondary use.
Right. The IUPC is a soft, flexible catheter that's inserted into the uterus. Its primary function is to provide objective, precise data on uterine activity. It accurately measures the strength, duration, and frequency of contractions, and crucially, the uterine resting tone between contractions. All of this is expressed in millimeters of mercury, MAHG, and this allows clinicians to calculate a specific metric called Montevideo units, or MVUs.
Montevideo units. That sounds like a key clinical measurement.
It is. MVUs are calculated by summing the intensity of all contractions in a 10-minute window. A laboring patient typically needs contractions strong enough to generate over 200 MVUs to ensure adequate progress in the active phase. So if the patient is on oxytocin augmentation and the MVU count is still low, the clinician knows they need to increase the oxytocin dose. If the MVU count is too high or the resting tone is elevated, it signals tachysystole and increased risk for fetal compromise.
That truly explains why internal monitoring is so critical for managing slow labor. Now, the secondary use of the IUPC amnio infusion.
Correct. The catheter has two purposes. Once it's inserted, it can be used to infuse sterile fluid, usually normal saline, directly into the amniotic cavity. This technique is used specifically to replace amniotic fluid, typically when there's oligohydramnios or loo fluid. But most commonly, it's used to cushion the umbilical cord if it's being repeatedly compressed by the contracting uterus. This cord compression usually manifests as those severe variable decelerations on the FHR tracing. The infusion of fluid helps relieve that pressure and often resolves the non-reassuring pattern.
Finally, before we are fully prepared for stage 2, we have to touch on antibiotic prophylaxis.
Yes, this is a critical, evidence-based public health measure aimed at protecting the newborn. Antibiotics must be administered to any patient who tests positive for Group B streptococcus or GBS. GBS is a common bacteria that, while usually harmless to the parent, can cause life-threatening infections like sepsis or meningitis in the newborn if it's transmitted during delivery. Prophylaxis, usually with IV penicillin, is also administered if the patient's GBS status is unknown. But they have additional risk factors like preterm labor or prolonged rupture of membranes. Safety for the neonate really drives this proactive step.
Okay, so the patient has made it to 10 centimeters dilation. Stage 1 is complete. We are now in stage 2, the pushing phase, which is all about expulsion. And the sources highlight that the shift here is immediate. Immediate pushing is now standard practice.
This represents a really significant shift in obstetrics. Historically, if a patient had an epidural, they might be allowed up to 2 hours of laboring down passively before starting to push actively. But the evidence is clear. The increased risk of adverse neonatal outcomes, including fetal distress and acidosis associated with delayed pushing, means that once full dilation is confirmed, immediate active pushing efforts are initiated. We're trying to utilize that window of full dilation efficiently.
How does the presence of an epidural affect the pushing effort? Can effective pain management actually hinder the mechanics of pushing?
It's a complex interaction. Effective pain management supports effective pushing by reducing exhaustion and anxiety, allowing the patient to focus their energy. However, if the epidural is recently placed, or if the patient receives a really dense, high concentration of anesthetic, it may result in a severe motor or sensory block. This means the patient might lack the sensation or motor control required to push effectively, and that could lengthen the second stage unnecessarily. The ideal is a lightened epidural that manages pain while preserving sufficient sensation for pushing awareness.
Now we get into the pure mechanics of delivery. Optimizing positioning and pushing techniques is key to expediting this.
Absolutely. The clinical focus shifts to active coaching, working with the patient to maximize the effect of their efforts. This involves promoting physiological positioning, using gravity to assist. Examples would be using a squat bar attached to the bed, having the patient push in a semi-sitting position, or even pushing on hands and knees, which often helps rotate the baby and widen the pelvic outlet.
And there's a crucial technique the sources warn against, a common intuitive way people push that is actually physiologically detrimental.
Yes. Clinicians must actively advise against sustained breath holding while bearing down. This technique, the Valsalva maneuver, while it feels instinctive, is actively harmful during labor.
Why is sustained breath holding so dangerous for the fetus?
The mechanism is circulatory. When the patient holds their breath tightly and pushes for a long duration, it drastically increases their intrathoracic pressure. This increased pressure decreases venous return of blood to the heart. When venous return drops, the mother's cardiac output falls, leading to a significant acute drop in placental perfusion and blood flow to the uterus. You're essentially compounding the oxygen interruption that the contraction is already causing, increasing the risk of fetal hypoxia. Instead, we coach for open glottis, pushing shorter, more natural pushes while allowing air to escape, sustaining oxygenation.
Beyond positioning, the clinician's job is to assess the geometry of the situation, the exact position of the fetal head. You mentioned before the importance of the occiput anterior versus posterior positions.
Identifying the position is crucial because it dictates the ease of delivery. The ideal position is occiput anterior, or OA. That's where the back of the fetal head is toward the mother's abdomen. The fetal head is flexed, and its narrowest diameter is navigating the pelvis first, kind of like a diver streamlining their entry into the water.
So what makes the occiput posterior, or OP, position so mechanically challenging?
In the occiput posterior position, the back of the fetal head is against the patient's spine. This often leads to deflection and a much wider diameter of the fetal head trying to pass through the narrowest parts of the maternal pelvis. It's like trying to navigate a tight corner with the widest part of a vehicle leading. This wider presenting diameter, combined with the often accompanying poor fit in the pelvis, what we call asynclitism, it drastically increases friction and resistance.
And the consequences of remaining OP are significant beyond just a long labor.
Absolutely. The consequences of the OP position include a significantly lengthened second stage, which is often much more painful due to the pressure on the patient's sacrum, and critically, a higher likelihood of leading to instrumental delivery, so forceps or vacuum, or ultimately proceeding to a C-section if the rotation doesn't occur naturally or manually.
So, if the fetus remains persistently OP as stage 2 begins, the source recommends an important skilled intervention.
Yes. The attempted manual rotation of the fetal head to occiput anterior, or OA. This is a deliberate, skilled maneuver where the clinician inserts their hand and uses finger pressure on the fetal skull to gently rotate the baby into the optimal OA position between contractions. The goal is twofold: to save the patient hours of exhausting, ineffective pushing, and to significantly increase the probability of a successful, safe vaginal delivery. It's a moment where a simple manual intervention can avert major surgery.
And stage 2 culminates with the controlled delivery of the neonate. This requires precision to ensure the safety of both mother and baby.
Precision is paramount, primarily to minimize maternal trauma and lacerations. Once the head is crowning, the clinician guides a controlled delivery of the fetal head, sometimes using what's called the modified Ritchen maneuver to maintain control and flex the head slightly. Once the head is delivered, the clinician applies gentle downward guidance to clear the anterior shoulder from under the pubic bone. After that anterior shoulder clears, an upward redirection is used to deliver the posterior shoulder. This sequential, controlled delivery minimizes any sudden, forceful stretching of the perineum.
The ultimate clinical objective of that sequence is really to prevent the severe lacerations, those third and fourth degree tears, that can cause long-term patient morbidity.
The moment the neonate is delivered, we transition immediately into stage 3. This is a rapid, active period focused entirely on the delivery of the placenta and, critically, the prevention of postpartum hemorrhage.
Before the focus pivots entirely to the placenta, there is a key decision regarding the umbilical cord clamping, which benefits the newborn.
The evidence strongly supports delayed umbilical cord clamping. The current recommendation is a delay of 30 to 60 seconds, unless, of course, the newborn requires immediate resuscitation or the mother has catastrophic hemorrhage.
What's the physiological benefit that justifies waiting up to a minute before clamping?
During those 30 to 60 seconds, the placenta acts as a reservoir, and the blood within it passively transfers back into the newborn. This process, often called placental transfusion, increases the newborn's total blood volume by as much as 30%. This significant boost in blood volume and red blood cells provides a vital increase in iron stores, which is a major long-term benefit for the neonate's neurodevelopment, and it helps prevent iron deficiency anemia in their first year of life.
Once the cord is clamped and cut, we immediately initiate active management of the third stage. Why is this active, hands-on approach so vital for maternal safety?
Because the primary risk of stage 3 is postpartum hemorrhage. The uterus is covered in blood vessels that were feeding the placenta, and it relies on a powerful contraction to clamp those vessels shut. Active management is a preventative strategy to ensure that powerful contraction occurs quickly. And this strategy involves 3 main components, performed in rapid succession. 1. Administering oxytocin. This is usually synthetic pitocin given intravenously or intramuscularly immediately after the delivery of the anterior shoulder. Oxytocin is a potent uterotonic that causes the uterus to contract forcefully and sustainedly. 2. Applying gentle downward traction on the umbilical cord. This assists the separation process once signs of detachment appear. And 3. Performing fundal massage. The clinician manually massages the top of the uterus, the fundus, externally to stimulate it to contract forcefully, ensuring the placenta shears off cleanly.
So, as the clinician is implementing this active management, they're watching for clinical signs that the placenta is actually separating from the uterine wall.
Yes, there are 3 classic signs that indicate successful placental separation. First, the umbilical cord noticeably lengthens outside the patient's body as the placenta descends into the lower uterine segment. Second, there will be a visible, though usually small, gush of blood as the separation occurs. And third, when the clinician palpates the abdomen, the uterus will rise and feel firmer and more globular in the abdomen as the detached placenta moves below it. Once those signs are evident, the clinician uses gentle traction to guide the placenta out.
Sometimes, despite all that active management, the placenta remains attached. That complication, a retained placenta, is a major cause of hemorrhage. How is that failure clinically defined?
Failure is defined if the placenta fails to separate and deliver after 30 minutes of active management. This is an urgent situation because the longer the placenta stays attached, the higher the risk of massive hemorrhage and infection. The immediate next step is an attempted manual extraction.
Describe the specific manual extraction procedure. It sounds invasive but necessary.
It is highly invasive, and it requires immense skill and attention to sterility. The procedure involves the clinician first supporting the outside of the uterus with one hand to stabilize it and prevent uterine inversion, which is a rare but catastrophic complication. The other hand is then fully inserted into the uterus following the umbilical cord. The practitioner must locate the plane where the placenta is attached, identify the natural separation point, the cleavage plane, and use gentle, sweeping up and down motions with the fingers to develop that plane and manually peel the placenta away from the uterine wall. The entire placenta is then brought out with the hand.
And if, in rare cases, even that skilled manual extraction is unsuccessful, what is the last resort to stop the bleeding?
If the retained placental tissue can't be removed manually, sometimes due to an abnormal adherence condition, the last resort is relocation to the operating room for a formal surgical procedure, a dilation and curettage, or DNC. This allows surgical visualization and scraping curettage of the uterine lining to ensure all tissue is removed and finally controlling the bleeding.
Moving into stage 4, the final clinical boundary, which focuses on immediate recovery, stabilization, and crucially, bonding.
Stage 4, the immediate postpartum period, lasts for the first 2 to 3 hours post-delivery. This time is characterized by intense maternal physiological adaptation and the establishment of the parent-newborn relationship.
On the clinical side, what are the key tasks that clinicians are focusing on during these initial hours to ensure the patient is stable?
The first critical tasks are assessment and repair. The clinician has to thoroughly inspect and repair any significant vulvar or vaginal lacerations that occur during delivery, classifying them by degree, first through fourth. Simultaneously, frequent, usually every 15-minute fundal exams must be performed, and the purpose of these checks is critical to ensure the uterus is remaining well contracted firm, not boggy, to confirm the body is effectively stemming blood loss, and to ensure vaginal bleeding is appropriate and not excessive.
And then there is the patient-centered aspect that makes this stage so beautiful, the golden hour of bonding.
This stage is where parent-newborn bonding is prioritized. The golden hour is a defined protocol where the baby is immediately placed on the patient's chest for continuous skin-to-skin contact right after delivery. The baby is dried and assessed right there on the chest, and typically not removed for weighing, measurements, or procedures for at least the first 60 minutes.
What are the physiological benefits of that immediate, continuous skin-to-skin contact beyond just the emotional bonding?
The benefits are profound and immediate for the baby. Skin-to-skin contact helps regulate the newborn's temperature, preventing hypothermia. It stabilizes their heart rate and respiratory rate, and it encourages the release of powerful bonding hormones like oxytocin and prolactin in both the parent and the baby. Furthermore, the baby is often alert and ready to root and latch for the first time during this window, which sets the stage for successful early breastfeeding initiation. Stage 4 is really the safe transition from the acute process of labor into the sustained recovery phase.
What a structured, in-depth journey through intrapartum care. The ability to break down such a complex, high-stakes experience into these 4 manageable stages is what makes this clinical guide so effective.
Absolutely. Let's do a final synthesis just to make sure we lock in the key management strategies for each stage.
In stage 1, the defining concept is the management based on that critical 6-centimeter threshold.
Yeah.
We have to distinguish between the latent phase, which demands expectant management and supports low intervention labor, versus the active phase, which requires higher vigilance and is the definitive point where interventions like AROM or oxytocin augmentation are used if the patient fails to progress.
Right. And stage 2 is the mechanical challenge. Here we focused on optimizing patient efforts, avoiding that detrimental Valsalva maneuver, and the clinician's skill in assessing and managing fetal presentation. The high-stakes intervention is the manual rotation of an occiput posterior presentation to the favorable occiput anterior to significantly improve the chance of a successful vaginal delivery.
Stage 3, delivery of the placenta, is all driven by hemorrhage prevention. We learned about the critical practice of delayed cord clamping 30 to 60 seconds for the newborn's long-term benefit, and that active hands-on management approach. The triad of administering oxytocin, applying gentle cord traction, and performing fundal massage. These steps actively ensure uterine contraction and minimize the risk of postpartum hemorrhage.
And finally, stage 4, immediate recovery. The clinician's focus is dual. Frequent clinical assessment via fundal checks and laceration repair, coupled with the critical social and emotional task of bonding and early breastfeeding initiation during that uninterrupted golden hour of skin-to-skin contact.
What really stands out when looking at the whole process is that constant vital balance. It's the balance between respecting the natural physiological power of labor and recognizing the specific, evidence-based points where a timely, targeted intervention is necessary to protect the safety and well-being of both the parent and the neonate.
Indeed. And as a final provocative thought for you to mull over, consider the fascinating dichotomy that truly defines modern patient-centered obstetrics. We discuss sophisticated high-tech tools like the IUPC, a device capable of calculating precise metrics like Montevideo units and performing targeted interventions like amnio infusion to cushion a compressed cord. Yet this highly technological precision exists right alongside the low-intervention strategies the sources also champion, such as hypnobirthing, water submersion, and hands and knees positioning.
High-tech measurement and low-tech intuition side by side.
How do these vastly different approaches, one deeply technological and quantifiable, the other rooted in intuitive movement and physiological trust, how do they coexist and inform each other to create the truly comprehensive care that defines modern intrapartum practice? It demonstrates the incredible breadth of the tools available to support the laboring patient today, ensuring that no matter the path, the goals of safety and dignity are always met.